very fortunate to have Dr. David Weintritt here from the National Breast Center, as well as his PA, Leah Ash, and his nurse, Michelle Reddick, with the Inova Mount Vernon Hospital. Today we're just going to talk about breast cancer awareness, just some of the basics. Feel free to ask any questions. If you're joining us from the link system, we are going to expand the screen afterwards. If you feel like you want to type in a question on the message, we'll be able to address that as well. So, Dr.
Weintritt. Thank you, Pam, for all of your invitation and for your courage and how well you've dealt with our relationship over the last couple of years. Welcome. It's very nice to meet you all in this format. The presentation today is basically an overview whenever I'm talking to, sometimes a group of clinical people or community groups who I'm trying to impart things that you all, the doctors, the community members, can hopefully take hold of and become advocates, whether it's perhaps for yourself or for a family member, a friend, because I think when I see at the level that I normally function at, what's going on relative to breast cancer care, and I'm a surgeon, but I tend to be the first point of contact, and then for a lot of patients, the ongoing point of contact. Maybe too, from a mentality standpoint, from a surgical approach, we're very proactive, very aggressive, very sort of forward-thinking, constantly trying to challenge the way things were done, because no one sees the impact of sort of doing things the old way all the time, like a surgeon does. And I've been in practice now for about 12 years and have been able to live through and help work through some really amazing innovations. So my goal with a talk like this is to hopefully give everyone some comfort level about, there are ways to manage screening and treatment, and there are so many amazing developments that occur in regards to how we look at, how we treat breast cancer, and we'll go over some of those today. I tried to keep statistical, I'm sure this crowd could probably handle some information along that line better than I could, out of it, although I'm happy to answer questions, obviously, relative to any part of it. But this is some of where we currently are, some of things that are now becoming available that we're very excited about, and then some of it will be information or technology discoveries that are going to lead to like the next wave, the next wave, the next wave of cancer care. So obviously screening is still important. The concept of doing mammography, I know everyone in this room knows what a mammogram is, and I know there's probably also the majority have heard some controversy about whether mammograms should be done or should not be done. So we'll definitely want to approach that. Understanding, so once something happens, just like, you all deal with your jobs every day. It's okay, you can identify an event, but then you need to kind of look inside and see what happened that led to that event, what's particular about this particular, this situation. Everybody's unique. We're all different in this room, obviously, although we have some similarities. So used to be, we would say, breast cancer would be like saying we're all humans. True, but there are significant differences. If we really want to truly understand what makes each one of us tick, that we now can determine. So the concept, when I'm talking to a new patient and I say, you've been diagnosed with breast cancer, and there are a lot of ways that still look at sort of lumping everyone together. But we very carefully and particularly now pull individuals and place them into very specific groups so that we can have them understand what issues they need to deal with in the present, in the future, why we would recommend certain treatments for them that maybe their sister didn't get or their neighbor didn't get. And it's great because everyone just has a much better understanding. The patients become much more comfortable with the treatment program, even if it ends up being intense, because they realize now, based upon science, why we would recommend something. Go ahead and go to the next. So it's always very important, and this is a very big deal, like clinically, when doctors, PAs, nurses are talking to patients and they're like wanting our expert opinion on things, that we remember there's sort of this concept of standard of care. I put it in quotations because for the most part, standard of care is an excellent benchmark that we have to think about whenever we're doing innovations. But I also see it in some cases as something that people kind of hide behind. Say, well, that's the standard of care. Well, this technique has been around for 5 or 10 years, and it's proven to be effective. Maybe it should become, now the standard of care. So there's kind of a push and pull dynamic going on anytime we make it to another level of new information, new treatments that we have to get everyone comfortable with. Some are obviously more ahead of the curve than others in that arena. Next one. And so then and that's really this issue. Like when I have things that I know work from a scientific standpoint, we have the data, and then every patient I talk to who that might be a candidate for the next 6 months has never heard of it. That's where the disconnect is, because I know it works. I know it's available because I've done it. They've never heard about it. I know the doctors that they're working with don't know either how to do it or about it. And so that's a really big issue where a lot of our time and effort is spent on trying to just awareness. If I'm not going to be able to operate on everyone who has breast cancer, we want to make sure that we're increasing the awareness so that whoever that person may see, it's sort of like it's in the room. They know that these things have to be discussed. So just to kind of create a framework too, this 230, 240,000 number has been fairly consistent. That's the expected annual number of new breast cancer diagnoses in the United States. What I think is really encouraging is for women who were diagnosed in the year 2014, basically 90% of them are expected to be alive in 5 years. There will be some drop in that number between years 5 and 10, but it becomes very minute the farther you go. So it's really critical for us to be thinking, for a lot of women, not so much the quantity of life, because we were proven that they're going to have a great quantity of life, but quality of life. And a lot of the techniques that are innovations have been geared or steered towards making that aspect of their lives better. So the aftercare. Again, if the assumption is that someone's going to do well, and if we can get the same outcome treating them in 2 weeks versus 6 months, with a significant difference in the risks and side effects, then it's very appropriate for us to be putting a lot of effort into that. Statistically, we can obviously go from 89 to 100, and that's our goal. But it doesn't mean that we should sort of forget about the 89%, and only focus on the 10 to 11%, because historically, a lot of the things that were done, would have women suffering some, potentially long-term, forever-lasting side effects. And when we can fix those, become again much more specific in how we treat, we do so. There's a buzzword of overdiagnosis that's used, at least in our community, and I think a lot of the articles that hit the press will comment on this as well. Oh my gosh, you've been treated, you might get diagnosed with a breast cancer that should not be treated. Not all breast cancers are cancers. They are for sure, again, a very wide spectrum, but the key is, as we're trying to develop ways of knowing which ones we can be very minimal in our approach and which ones we have to be very aggressive in our approach, it is very dangerous in my mind to be getting the concept of a breast cancer that requires no treatment out, because number one, we do not have a single test that's capable of telling us which breast cancer that may be. So I think our focus should not be so much now on overdiagnosis, but not on overtreatment. Next. The curve here, you see basically increased peak incidence right in the postmenopausal 55 to 65-year-old for new cancer diagnoses. The reason why this is important is the task force, the U.S. Preventative Service Task Force, basically recommended taking anybody to the left of that curve and say, we're no longer going to screen this population. And in that scenario, for me, I'm thinking, man, that's like 30% of the new cancer diagnoses that are being told not to do anything. Self-exams are worthless. Mammograms are worthless. So rather than just sort of say, maybe some of the technology that we used in the past had a hard time dealing with these, recognize that a lot of the technology we use now actually can deal with these women, and that we can create other ways, of screening them, allocating like risk assessment, those kind of things, to not forget about this very important population. Next. This shows you basically that if you're diagnosed with breast cancer at an early stage, either confined to the breast, which is the localized there, in the breast as well as in the lymph nodes, but not elsewhere, the 5-year survival is excellent. And that is not something that has been around for a long, long time, because when you look at the data that's mined for survival, the survival has improved about 30% over the last 15 to 20 years. And it's based a lot on screening. And it's based some on new technology. And it's based a lot on, there's massive importance, as you could see from that graph before, about finding breast cancers at an earlier stage. We want this group to continue to grow, and what's one thing that has shown the ability to produce more of these and fewer of these are some of the new mammographic techniques. It's been proven that some of the digital and 3D mammogram images are, number one, better at looking at women under the age of 50, thank God, because that was a group that some of the other task forces said we had no option for. They're better at finding breast cancers that are true invasive cancers but that are confined to the breast, which again, thank God, because you saw that if you're in this group, your survival is phenomenal. It's almost 100%. Next. So we screen, obviously, go ahead. So mammography, MRI and ultrasound are tests that can be done for lots of parts of the body, but they're very useful in breast imaging. That's one part. But another thing that's really critical is risk assessment. So any patient that comes to our clinic, and again, we try and also provide education for other primary care practices about identifying risk factors. The vast majority of new cancer diagnoses are what we call spontaneous mutations. They happen in someone completely independent of their family history. The BRCA, probably soon to be renamed the Angelina Jolie gene, is only really happens in about 3 to 5% of breast cancers. So the other 90% plus have nothing to do with the mutation. And there are some other syndromes too that account for a very minute part, but the key is for women who don't have a family history to not have some false sense of security that nothing will ever happen. I don't want you to panic thinking that something is inevitable, or to think that you shouldn't adhere to a screening program, because that is still very helpful. But if there is a family history, and if there then there are certain things that need to occur, testing like this, because if this occurs in a patient of ours, if we don't act preventatively from a surgical perspective, their likelihood of living goes down. That's really the only scenario where that exists. Every other patient who has breast cancer, we can treat sort of whatever the scenario is, and not have to worry about preventative removal of the other breast, the ovaries, all those issues. Is from a survival standpoint. But these women act completely different. So when we're still in this screening mode, we have to find these patients. Next. All right, so mammography, and we'll kind of go through these, because I think the take-home point from as far as the whole mammogram issue, if you look at the studies that have been published in the lay press over the last few years, they're either looking at techniques that are outdated, so they're basing their assumptions and their information on ways of imaging the breast that we wouldn't even consider doing anymore. And they're saying that because of how these pictures look, this test is not useful unless you're over the age of 55. We sort of agreed with that, 20 years ago, but we're a little bit past that now. So they're sort of fixated on something in the past and not aware of what's going on in the future, or they're focusing on survival. And if you go back to that earlier statistic of 90% of women who are diagnosed with breast cancer are going to survive, that number is not going to move that far that fast. I mean, there's only a small amount that's still able to go. So I think mammography gets asked in many cases to do something that it's not capable of, but it doesn't mean that it's a worthless test. So these issues, they're sort of focusing on, well, mammogram, we still have 40,000 women who die from breast cancer every year. That's mammogram's fault. It's not mammogram's fault. It's a biological type or certain biological types of breast cancer that are very aggressive, and if they occur, whether they're found as a smallish lump or a big lump, their risk of spreading and creating harm and eventual fatality is not going to differ based upon how big it was when it was found by the mammogram. But then there is a completely other subset or population in the majority of breast cancers where that does make a difference. Next. And that's just, again, the task force, the Canadian trial. Those are two things that we talk a lot about at our meetings because we're more so not like, oh, thank God something finally proved that we can stop doing mammograms. It's really more a matter of let's dig into these things and figure out why people were making these conclusions. And the conclusions were either based upon incredibly horrible studies or old technology. Next. And this is just a visual example of what's happened. So a lot of the recommendations are made back when everything looked like this, and none of them are based upon things that look like this. What does happen when you go from taking pictures of this nature to this nature, and by the way, this is a digital image, so you can manipulate it, you can do computer-assisted diagnosis, there's all kinds of ways that you can look even better at this. You reduce the mortality of breast cancer by that 30% number. Next. So these techniques, this group, used to be thought, we have no hope for you. We do. The 3D studies, which are appropriate, and I think at some point in time, does anyone in the room not know what a 3D mammogram is? It's essentially just an additional way the software is able to look through the breast layer by layer. So you get the traditional global picture, and then the radiologist can scroll down through the breast and find much smaller lesions. And so the anxiety associated with mammography decreases because there are fewer scenarios where, Ms. Jones, your mammogram showed something. We need you to come back next week and take some more pictures. What's going on. That's real. We all appreciate that. That happens less. And finding these invasive, yet to spread to the lymph nodes cancers increases. Okay, next. There's an issue about breast density. It was about a year ago that Virginia law passed requiring anyone who has a mammogram for their report to comment on the density of the breast. And this is actually very good. It's very appropriate because now we're getting into saying, okay, the majority of people in this room have breasts, but they're not going to all be the same. But if you sort of assume that they are, then again, we're going to be doing a little bit more in some than we should and not as much in others as we should. Next. So we break breast density into 4 different groups. It's very convenient. There's those who are extremely dense. There are those who have almost no glandular tissue and it's sort of transparent, which makes the mammogram very easy to read. And then there's, as with everything else, sort of all the women that are in between. Next. The risk of density causing cancer is only increased in women with extremely dense tissue, and that accounts for only about 10%. So it's good to be aware that breast density, while real, is not a huge risk factor for the vast majority of women. This other group, this heterogeneous group, which accounts for about 40%, there is no increase in the risk of cancer, but there can be some limitations as far as how well the mammogram sees the tissue. So those are women where we would recommend the 3D. Those are women where we might add something like ultrasound to their exam so that we can very clearly see things that were otherwise maybe not so clear. Next. Yes, ma'am.
When the mammogram comes back and it says this blanket statement, you may have dense breast tissue, and I can't remember what the...
Right.
But it doesn't specify one of those four categories. What does that blanket
Well,
statement mean? Are they trying to meet the letter of the Virginia law and just not make a call?
so here's the issue with, so the letter I get and the letter you get are completely different.
Okay.
And that's not good. No one should be afraid of informing, patients of what their report showed. The letter I get will say specifically which, quartile it's in. The letter you get will just be basically one long disclaimer. And in some places are actually getting much better and much more informative, and they'll basically say, this is exactly what your report showed, and this would be the appropriate way of dealing with it. Not everybody is at that point. So I think, unfortunately, all these reports, like the letter that gets sent out, is to make sure that this loop is closed from a legal standpoint, but it's not very helpful information. So I would strongly recommend everyone to say, I want a copy of my report so that you can very clearly see exactly what it showed. MRI is a very sophisticated way of imaging. There are some women that benefit from screening MRI, but that's, again, a fairly small group. We use it to assess cancers because I can create all kinds of three-dimensional imagery and plans from MRI so that when I'm trying to contemplate the appropriate operation to recommend for someone. Next. You can see that the screening is great for the Angelina Jolie patients who choose not to do prophylactic surgery and a couple of other genetic situations. Women who have a calculated increased risk based upon family history, or maybe they've had a biopsy before that showed some precancerous cells, or a very small group of patients who had radiation typically for a lymphoma when they were in like the ages of 10 to 30, I think. And then we use it lots for evaluating certain symptoms that other tests are not really giving a clear answer for. Next. Ultrasound. Ultrasound is sort of like a third arm for me because I can use it in the clinic. I use it in the operating room. I get information back in about 10 seconds. Every procedure that I do is oftentimes guided by ultrasound. There's no radiation associated with it. It's very cheap. So the ultrasound technology has really boomed, and there are these like laptop, mine's on a Apple PowerBook, and it basically, I can go take it with me wherever I go. And what this is really meant to represent, this is a frozen image of a digital ultrasound, and so the skin is up here. This is the fatty layer of tissue under the skin. This is the dense breast tissue. This is a woman who had like that mammogram image where everything was just sort of whited out. This is another layer of fat behind the breast, the chest wall. This is the periosteum over one of the ribs, and this is the beginning of the surface of the lung. So there is no decrease in the ability to see things as you go through, as long as you're getting the settings correct. I can even see a tiny little ligament heading from the breast up to the skin, one of the suspensory Cooper ligaments. So the concept of dealing with like a mammogram in the past that said it was just like really dense, you're 45, you should probably just stop getting mammograms. No. We should just consider adding something like this so that things that may not be seen that clearly, we can see. This is not going to replace mammography because there are some things mammogram sees that ultrasound doesn't. It's also a little bit more labor intensive to screen someone with ultrasound, but it's a really useful tool in the right setting. Thanks. Okay, so now the understanding of breast cancer. This is how sort of the vernacular that is commonly used to describe breast cancers. It is information that we still pay attention to because it's how sort of we communicate. It's very useful. We make sure we tell patients this information because when they go on the web, and everyone will, this is how their features will be sort of compared. But the real story that exists now and which will take hold in the future is genomics. It's the DNA of the cancer. You know, we sequence the genome of a normal human, we can sequence the genes of a cancer. And so there are assays that look at different gene panels. There's a study where we look at the protein products of cancers, and that's honestly how I predominantly look when I'm making decisions. I care about tumor size maybe because it's relevant for perhaps the right surgery we should do. I care about the nodal status because it helps me know to expect maybe whether that patient's going to need radiation after their mastectomy or not. But I really care about this when I'm trying to tell them, you know, this is the group that you fit in. This is what your future will look like if we don't do certain things. Next. I mean, it's literally gone from this large amount of money to, you know, commercial labs will sequence your, you guys do it all the time probably. I mean, for less than $10,000. And the tests that we run where we're sequencing the cancer DNA, they run about $3,500. And that obviously, you know, it's just going to come down and down and down and down. And this was a company from the Netherlands Cancer Institute, which made what I firmly believe to be the best test that's available on the market now. And it's obviously, you know, it's a play on things, but it's an apples to apples comparison because, you know, when I see patients all the time, maybe they come to me as a second opinion and they said, well, Dr. So-and-so, who I know, who's very well respected and who I know is a good doctor, said that I should do chemotherapy, you know, to try and shrink my cancer down, you know, and then come back, you know, 4 to 6 months later and do surgery. That is perfectly appropriate in some situations, but that is massively inappropriate in others. And if you're basing your decision to do treatments like that off of old information, like just how big it is or how young, you know, the person is, then you're going to mistreat or miss the right approach for many. I just operated on someone earlier this week who had that exact scenario occur. And the mammoprint analysis that we did in this patient, you can go to the next slide, basically showed that her cancer type doesn't respond to chemotherapy. And in this particular situation, in a good way, because hormonal therapy, a pill form, would be equally effective. And so she would have, in that scenario, undergone 4 months of cytotoxic chemotherapy, which would not have changed her cancer. It would have looked the same, you know, in the fall as it did now. That treatment would not have been, is not going to be necessary for her after surgery. And it would have been a completely appropriate, again, sort of 10 years ago, 20 years ago kind of concept. It would have been very cutting edge back then. But now we should, and this is, I think, from an advocacy standpoint, you know, for those of you, if you know someone, and there's no one who's an adult who won't know someone who's diagnosed with breast cancer, whether it's, you know, their spouse, relative, friend, whatever the case may be, just to say like, hey, I know that there are some ways that cancer can be analyzed that are a little bit different, you know, than ways before, something you may want to ask your doctor or look into. I go to meetings all the time where that concept is still having a hard time taking hold, and it drives me crazy because it is, you know, the whole concept of like, I'm a doctor, I know what to do, you know, like, yeah, you're still making decisions, you're just making better decisions with this information. So we're going from looking at things under the microscope to the microarray. The microscope is still important. It tells me whether I removed all the cancer or not, you know, whether someone might need an additional operation. It makes the initial diagnosis so that we then know we need to do all of these tests. But that should not be how critical decisions regarding chemotherapy are made. Next. And this, again, like whenever I'm in these meetings, sorry, it got kind of contracted, is if anyone looks at this slide and they say, okay, most all doctors at one point in time, we took anatomy and physiology and biochemistry, and you know that from the moment that a cancer cell occurs to all these different steps that have to happen for it to go from point of origin to distant point, live, grow, and that's really where when anyone dies from cancer, the vast majority is because the cancer metastasizes and sort of becomes an overwhelming impact on the body. Next slide. It doesn't just happen, oh, can you go back? It doesn't just happen in every situation. All these are gene sequences. These are all things, these are all steps along the pathway, like mutations the cancers have to acquire in order to be able to do these things. That test, you know, with the nice catalog with the red and the green apple, these are all the genes that it looks at. And so if you think about, like, you know, pick one of these steps, or, you know, and if there's a cancer that's completely lacking in the ability to invade through the wall of a blood vessel or whatever feature it is that we know may be required, but it has some other features that are aggressive, you could easily see why in the past someone may have said, you know, we need to do chemo here, but you can scientifically see why you don't, because this cancer is not capable of spreading. Next. This is an example of how we compare, again, the sort of chemo or not chemo scenario. When this analysis comes back showing that the patient is low risk, these two colored curves, the looks like blue and orange, they basically don't differ. The orange would be women who received chemo, the blue would be the ones who did not, and you can see there's very little deviation and no statistical significance. However, if we do this analysis and we see that their risk is high, and how does that get determined? That whole array, all those genes that you see of like step to step to step to step, if they're present in the right or wrong combination perhaps, they're high risk. Now there's a huge difference in survival, and we want to make sure that those women are appropriately treated. Next. We do molecular subtyping, you know, so again, we can predict response to chemotherapy. We know additional medications that are applied. That's how we should be describing breast cancers now. Next. So treating, we'll kind of move through this. I think the take-home points from the treatment part are that we have a lot of options. There really are not so much any radical surgeries anymore. That still may occur in some situations, but we're very, very aware conceptually of making sure that, again, if someone's going to be alive forever and ever, amen, that, you know, we can have that woman be very comfortable, happy in regards to how they feel. We have a lot of patients that look, honestly, I'm not being judgmental, better after the surgery than they did before, because we're incorporating the cosmetic element into how the surgery is done, and not like this sort of, in the past when I was trained, you know, the surgeon would go in, the breast surgeon would go in, sort of just scorched earth policy, you know, we're removing everything, and then 3 months later send the patient to a plastic surgeon who would then, you know, try and sort of put everything together. There still are situations where that may be appropriate, but we're always thinking about, you know, combining everything. And the real important thing, what I tell patients who are diagnosed, who come in and say, Dr. Weintritt, I want a bilateral mastectomy tomorrow. And, you know, the issue is, again, we have to say, for what reason? Let's think about why. There is no difference unless someone has a genetic mutation for women who have a lumpectomy versus a mastectomy from a survival standpoint. There may be medical reasons to do mastectomy based on the size of the cancer. Some women may choose to do bilateral mastectomies because they really are incredibly anxious or fearful about what future issues may occur, their screening. As long as it's being chosen for the right reason, we have no problem with it. We're very good at it. But it shouldn't be something that's forced upon, you know, women just because, you know, that's what the medical community says should happen. Next. And then lastly, we'll talk a little bit about radiation, because this is one of the other advances that will not change the survival curve, but in many situations affects the quality of life curve. So this sort of, again, standard of care, which in some cases may not be appropriate, in many cases still is appropriate. There's whole breast radiation. So when we have to treat a large area, the chest wall, the lymph nodes, there is the technique that has been done for decades is the right way to go, because there is no sort of cone down beam or seed that can help purify that large of an area. But there are situations where, as you saw with one of the earlier slides, where we're now finding women who have smaller cancers confined to the breast, where we really shouldn't be treating all of these unaffected areas. Next. And so what I've seen is, when you're dealing specifically with the concept or element of radiation, is we've gone from 2 months to 2 weeks to 2 hours. So there are some treatment plans that are available now that we do, where the combination of surgery and radiation, which is what we call local control, which would have previously taken 2 months and still in some cases should take and needs to take 2 months, can be done in 2 hours. So patient goes home, surgery's done, radiation's done, because it all happens together during the operation, and they are past that point ready to move on and get back to their life. This is just one of the methods that we apply that treatment, by placing catheters that have multiple struts that allow radioactive seed to treat a targeted area. Next slide. These are a couple of machines that are capable of delivering a similar treatment in the operating room, where we conform the breast tissue around appropriately chosen sized applicator and treat the tissue during surgery. Next. We're going to go through this. These are just selection criteria that basically say that how we kind of determine who to treat, who not to treat. It all makes perfect sense. Because why? We're not just making decisions based upon arbitrary features. We're looking at very specific pieces of information, and we're placing women into the appropriate category. Next. Next. So the synopsis of, and Lord knows what exists in this building, no one would sort of go through their daily life interfacing with any of this stuff anymore. It's just not going to happen. Yet, a lot of information or recommendation about how you should sort of interface in regards to your well-being and your health happens with things that were around during this era. And it's really just the awareness and the acknowledgement that technology has changed things, and we should be aware of what, limitations, agree, but don't just stop doing something because maybe it wasn't the best thing in the world in the past. Figure out a way to make it better. Next. So from conclusion is every aspect, from trying to, say if we sat down and had all of you fill out a questionnaire to know at my age and for the future what screening program would be appropriate for me. Perfect, can do that. So that's improving. For anybody who gets diagnosed, what does my cancer look like? What should I be doing? Absolutely perfect. We can tell that no. We can create other ways. Give them other options. Advocacy is huge, because until the day when I have patients come into my clinic and say, Dr. Weintritt, I've been diagnosed with breast cancer, and I want to know, do you do this, 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 and this? Instead of me saying, did you know that we could do this, 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 and this? And they're like, huh? And we go and talk to other doctors and let them know about all these things that exist, and they've never heard of it. Or, there are people in the medical community who are reticent to sort of embrace some of these things. Change is sort of, everybody has to deal with it and somewhat maybe resistant to, but we all have to advocate for ourselves to make sure that we're getting the right appropriate care. And then the concept of survival, I'm going to a wake this afternoon for a patient of mine who died from breast cancer last week. So I'm very aware of the need to do better when it comes to survival. However, for the other 90%, we should be very respectful of making sure that their lives, while they're blessed to still be around those with them, are fuller, happier, healthier, by not necessarily worrying about overdiagnosing them, but that we don't overtreat them. And that concludes the talk. So thank you all for paying attention. I know it was a lot of information, and I appreciate you being here, and that the knowledge that I know that, whenever I'm speaking to a group, or Leo or Michelle are talking to a group, is that who knows who may benefit, from the information, but that we want it to get out there into the community, and so that these things which exist, which are proven, will become the new standard of care. Thank you. Yes, ma'am.
Actually, I have a lot of questions, but I will reframe and restrict my comment to a very heartfelt thank you for your advocacy of fast information and throughput. Just in that initial stage, I had two very dear friends go through treatment, one 5+ years ago, one very recently, and the angst in the life of this first breast cancer patient was so tremendous, from month to month waiting for results to get back and waiting to get to contact the next doctor and then the next doctor. To be able to compare that to a recent friend's experience of 2 weeks, she knows what's going on, is just tremendous. It's just amazing. I'm really crazy for valuing that part of that life experience. It's so makes such a difference.
Well, you're welcome. I think if most doctors, look, it's tough. Practicing medicine is not really all that easy, in the year 2014, but it's still very enjoyable. And I think if most people just basically said, if I'm in your shoes, how would I want this sequence to play out, then, it's not that hard to figure out, ways to get things done. Welcome.
A question up here, but I think it was probably earlier in the talk of what is not staged.
Oh, not staged. Well, sometimes that was just basically looking at data, and all data collection, as you know, it may not always be perfect. And so we had information on the vast majority of patients, but there was a small subset included in one of those survival analyses that they actually didn't have enough accurate information on what their stage was. So instead of throwing them out and potentially skewing, the results, they included this group that they just didn't know what their stage was. So that's what that meant.
We can go back and forth, and there's going to be questions up on the screen, but if anyone in the audience has questions as well.
Yes.
I have a cousin who was 35 and she lost her fight 2 months ago. It wasn't long. It was only about a year. She had the BRCA1
Mutation. Mm-hmm.
How is that? Do I need to be worried about that? Does
So-
her sister need to be worried about that?
Well, yes. So with these mutations, the BRCA mutations, they are very potent, but it's basically a 50-50 proposition. The inheritance pattern means that, if you're looking at the family tree, and that's really what, needs to happen. So we do a lot of genetic testing, but as soon as one of my patients tests positive, for a mutation, I'll have them meet with a genetic counselor, because they need to have someone who will spend however much time is needed to map out the whole family, and then inform that person as well as their relatives. You are at risk of carrying this mutation. Now, once you get past a certain point, you can stop, because it doesn't skip like generations. So if say if you have a mother who's diagnosed, and that mom has 3 children, 2 of them tests positive for the BRCA mutation, one doesn't. That one who didn't, their children would never have to worry about being tested, okay, because it's not going to skip. The two that tested positive, say they each have 2 kids, it's 50-50 for their children. So you do have to follow it just like a lead, until you get to the point where you've sort of traced this to the end point where you are getting.
Find out where she got it.
Yeah, it was from one of her, so likely from one of her parents. Now, again, these things most of them are passed down from like long lineage ancestry. It's possible that someone could be the first one, that they developed a mutation that fits into the profile of a BRCA gene. But in almost all cases, you can see, like it most likely came from your mom because, whoa, look at that history. There are a lot of patients who don't really know their family history. They came from another country. Their parents died at an early age. They only had one other female relative. So the key is every person who is a primary relative to someone who's been diagnosed with a mutation should be tested. Sister, brother, parent, child, okay? And then from there, if any of those points hit negative, you stop. But if it hits positive, then that person now becomes that epicenter, and every primary relative around them should be tested. So you'll connect cousin to cousin via aunt, uncle, whoever. Find out, ideally. And if it's a scenario where, excuse me, people may refuse to do testing, we see that sometimes. Again, maybe the other the linkage between the two of you may have passed away. Most likely you would qualify for the testing because there's sort of this limited family clause. So, and it becomes quite simple because when a specimen is collected from someone that we know has a gene mutation in their family, the test only runs for that specific mutation. You don't need the whole panel, it's just that one. But it absolutely, should be traced to the point where you see it stop.
You have a question? When should women start getting screened if they have a family history of breast cancer?
So that's where family history is important because not all family histories are the same. A lot of women are assumed to be high risk because they had an aunt who was diagnosed with breast cancer at the age of 80. That's not the case. That woman is okay. But if we see multiple family members, primary relatives, women diagnosed early ages, especially premenopausal, then you have to, number one, determine if genetic testing should be part of screening. And then number two, we still use some of the older concepts of 10 years before the diagnosis of the youngest relative. As we've seen, we now have the capability of imaging, women who are in their 30s, if it's appropriate. If the relatives are all over the age of 50, then it's still fine to wait until the age of 40 to begin screening. We recommend when family history we believe is actually true, even for women who aren't BRCA carriers, that we improve their clinical screening so they're, sort of go to the doctor twice a year instead of once a year. We look to see, we do risk analysis, and so we go through a series of questions and find out if their lifetime risk is expected to be over that 20% threshold, because now we can potentially add MRI to their screening. And then we look at the breast density. So it's so multifactorial now. So really, you can't answer that question with one specific answer other than to say you got to go and have someone who knows what they're talking about go through your history, personal features, family features, and then you'll get from that person an appropriate screening plan for you.
Who is the appropriate person to go to for that? Because my general doctor's not going to look at
Yeah.
that kind of information and come up with anything useful.
Sure. Well, obviously, I think most, like we call breast surgeons, which is what my profession is, are capable. However, not all practices of that nature will take patients just from that standpoint. Some will basically say, like, I don't want to be called until there's a proven problem. I think for us, it's a big issue to sort of be proactive. A lot of medical oncologists, like the chemotherapy doctors, they sometimes have resources. I mean, like if hospitals have nurse navigators like Michelle, they know the risk factors. So in most, like around here, whether you go north, south, or west, I don't know about east, there's going to be a facility not that far that has, either someone hopefully like me or like Michelle, who could answer those questions.
What would that service be called?
Well,
Like a pre-screening?
so some programs will have a high-risk clinic, so that's oftentimes what it's called. The genetic counselors as well, like our healthcare system, the genetic counselors are a free service. And so, if someone has a family history, they can go sit down, just like somebody who calls 911. It's not always going to be a true emergency. Paramedics are still going to come check it out. So they'll sit down, and they'll go through things and say, it's okay, you're fine. Now, they're not going to deal with issues like breast density. They may not go through a questionnaire to find out about lifetime risk. So that's where, like the nurses like Michelle, PAs like Leah, myself, the medical oncologist, it really takes something. But if you have no family history, no personal history, you don't need to be doing, a questionnaire. You don't need to really be doing genetic testing. That's though when it's important, with the mammogram issue, because then breast density may become someone's sole risk factor, and they need to know about that. Jimmy, answer your other online question.
So chemo radiation normally recommended with a mastectomy?
This is a concept that's really important when I talk to patients. There are two types of recurrence or disease control we have to think about. Local, which would be getting the cancer gone and having it not come back here. And then distant, which would be will the cancer ever spread somewhere else in the body? They are very independent pathways. So while in some cases you will see women who have a mastectomy, radiation, and chemotherapy, kind of one of everything, it may have been because they had a large cancer in the lymph nodes, so they needed, both aggressive local and systemic therapies. But they are by no means tied together. And I think that may be some of the concept of, some patients will say, well, I want a mastectomy so I don't have to do chemo. And, the answer is, well, that's not really the case. That's not how it works. Because you can have a fairly small cancer that we do this genomic testing that says it has a high risk of spread if you don't undergo chemotherapy. But in the same token, that cancer was small enough that we can very easily do surgery and preserve the breast. So you'll have women who have a mastectomy who don't need chemo, and women who have a lumpectomy who do. So there's no direct correlation. Is there one other question on there above that one? Okay. Perfect. This is I think one of my kids is online, I think.
So actually, I had a question. Something came up at the support group last night about a screening mammogram versus a comprehensive mammogram.
Yeah.
Is that something that a patient should be aware of, or is that something really on the doctor?
It's a little more on the doctor's side. If you get a screening mammogram, you're not getting shortchanged, from a technology standpoint. It's really more the process. So if I order a mammogram for someone who has no active issues, and it's just sort of time for them to get a mammogram, then it'll be a screening study. If it's someone who I wanted to follow up on something that was previously seen, or I'm aware that there may be something going on, then it's comprehensive. The only difference is if you go screening route, you go in, you get the picture, the tech looks at the images, confirms that they're appropriate, and you go home. If you get a comprehensive study, same pictures happen, same tech looks at it, yep, hold on, the doctor's got to take a look at this, make sure that there isn't anything else we need to do in the moment. So they basically just keep you there until whatever studies appropriate need to be done. So the comprehensive mammograms are more expensive, because of the sort of the process involved. So we order lots of screening studies, even though we have a skewed higher risk population, because it's the same picture. All right, everyone.
Thank you.
You're welcome.